Hello, this is Chapter 8, Strength and Evidence-Based Helping Strategies, lecture video part 2. So in this chapter, or in this lecture video, I should say, we're going to continue on with solution-focused therapy and cognitive behavioral therapy, and also touch upon group therapy at the end. So solution-focused therapy. I have a surprise fact for you. 79% of addiction counselors endorse strengths-based practice in constructing goals with a client, despite their belief of 45% of these in a disease concept. So not everybody believes in the disease concept, but 79% of addiction counselors are actually focused more on the strengths-based than working with that disease model concept. So I feel like I fit into that category, so I had to give you that surprise fact there. Some techniques of solution-focused therapy are the miracle question. You're asking for exceptions to the problem, scaling questions, and coping questions. I have a very love-hate relationship with the miracle question. I love to hate it or hate to love it. I'm not sure. But it's something that I think is forever instilled in my brain. So I'm going to give you a little bit of insight on that. And let you know how I found myself actually using this once in one of my therapy sessions. So the miracle question is where you are working with a client and you're asking them to kind of think that one night when they go to sleep and they're sleeping, they don't really know that anything is going on. They don't know that a miracle happens overnight. So the first question is what would be the miracle that they want to happen? What would happen while they were sleeping? When they wake up in the morning, what would be the first thing that they would notice that a miracle happened to them? What would people around them notice that this miracle happened? What are some things that, what would they feel? How would they act? What would be different if this miracle had happened overnight? Getting them to kind of visualize, okay, so this miracle is actually the solution to their problem, and it's what they would want to see coming out of it, but it's not directly coming out and asking them, hey, so you have this issue that you came to me with, what do you want to see happen? It's kind of a different approach to it, a less invasive approach, I guess you could say, because you're kind of getting them to kind of visualize or fantasize about, okay, so I really want this to happen. And then, you're kind of getting them to think, okay, so this miracle, what are some ways that this miracle has already been happening in your life? What are some things that didn't work with this miracle? And you're getting them to kind of identify all of those problem areas and all those, positive strength areas that you could focus on and kind of get them to keep working on. So after you do the miracle question, you're following up to better illustrate what that goal is or what that person wants to see or what their miracle is, even though they don't really realize that they're doing it. You're getting them to have scaling questions. So we mentioned scaling questions in the previous lecture video on a scale of 0 to 10. How much do you think your life is like this miracle right now? And getting them to kind of see, okay, well, so you said a 5, what would make it a 6? What would make it more like that miracle? And you're getting them to kind of fill in their own gaps to this fantasy that they have. Exception questions would come after your scaling questions. So you're asking the client to remember a time in their life when part of this miracle may have already happened. You're figuring out what that time was like, what worked, what didn't work, so that you can kind of build off of that. It's giving the therapist groundwork to kind of keep moving forward. The last step of questions would be your coping questions. Well, how did you do this? How did you deal with this? How did you deal with that? How have you managed or dealt in the past? How are you dealing right now? Because when a client comes in, 9 times out of 10, they already have some of these skills. They just don't really realize that they have these skills and may need someone to kind of help intervene and show them what they're already doing may be working for them. A not knowing stance is fundamental when you're working with solution-focused therapy. You want to kind of play not like a guessing game, but like a detective game. Like you want to explore them and explore what their miracle is. Some research on effectiveness with solution-focused therapy. There was a meta-analysis, 15 controlled outcome studies, and it ruled it effective. Researcher Cynthia Franklin had said at least as effective as other current treatment models, and for some problems more effective and considerably more cost-effective. So there is proof that it is effective out there. I know that, at first I thought it was silly asking someone, well, what's your miracle? But when I was, a few months into my drug and alcohol therapy, and I was working with clients, I found myself asking them similar questions to this miracle question, parts of it. And I realized that, it was beneficial to work with them because, again, they're coming in at some of their worst times and you're kind of giving them a way to kind of fantasize about a hopeful time for them. All right, let's move on to cognitive behavioral therapy. I like working with this type of therapy as well because bad thinking leads to bad thoughts, bad habits, bad actions. If you learn to think differently, you will act differently, you will behave differently. Belief that you can change the cycle of thinking. And this sounds crazy, but it is possible to do. I am a firm believer that if, you keep having negative thoughts, they're eventually going to downward spiral. And negativity just surrounds negativity. You ever hear that statement? Misery loves company. So I feel like that's kind of what happens when we get these negative thoughts in our head. So you start with one thought and it spirals out of control, and pretty soon you have this grand plan of negativity in your head. But if you trade that in with positive things and you slowly start to add positive thoughts into your life, your mood changes, your demeanor changes, and those that you surround yourself with changes. And pretty soon more positive things happen just by that positive thought. Sounds crazy, but I believe in that. There are some waves to cognitive behavioral therapy. It's a theory and practice. The first wave could be viewed as the developmental phase, and the second phase is the recognition of the link between dysfunctional cognitions and maladaptive behaviors. Lastly, the third wave includes approaches such as DBT, MBCT, which is mindfulness-based cognitive therapy, and DBT is dialectical behavioral therapy, ACT, acceptance and commitment therapy. So sessions in cognitive behavioral therapy kind of follow, these strategies, I guess I should say. So we have skill development, identifying triggers, reflective listening, empathy, rolling with resistance, and role playing. Role playing is really important with cognitive behavioral therapy because it's getting them to kind of practice those skills. So you could give them a whole list of things, but if they're not actually acting them out or they're not working or practicing on them, they're really useless for them. And I feel like role playing is good because you could have that client identify real life situations that they may encounter on their own and kind of get them to start thinking in that mindset of, okay, so when this happens to me, this is how I'm going to respond or react. Cognitive behavioral therapy uses the ABC emotion model. A stands for an activating event, B stands for one's interpretation of the belief about the event, and C stands for the consequences of such that interpretation. So, the activating event may be seeing your drug dealer. B is you believe, okay, well, I saw my drug dealer, that means I need to use. And then the consequence to the event is I could go to jail or I could get in trouble with the police. Unlike solution-focused therapy, the client has to be willing to cooperate with cognitive behavioral therapy because it's their thoughts that they're changing. And it's not a conversation with them. It's not getting them to talk about their issues. It's actually application of skills or strategies. We had mentioned that third wave before for cognitive behavioral therapy, the ACT, DBT, and MBCT. So all three of those therapies use mindfulness, which is focusing on thoughts and feelings. The ACT therapy, the acceptance and commitment therapy, is accepting painful or uncomfortable thoughts and feelings rather than trying to shut them out and using one's values to make commitments. So accepting the fact that we are having these thoughts but not dwelling on them and moving on with them. A way that I had clients work with this is that I would tell them to set aside maybe 10 or 15 minutes out of their day where they allow themselves to feel that hurt, that pain, that anger, whatever negative emotion that they had that I was working with. They would allow themselves to feel that. And it sounds crazy, but 9 times out of 10, if you have that scheduled into your schedule, you're not really, it doesn't become as important or doesn't become as fixated on. The brain doesn't fixate on it as much. Now, if you would come up with a thought and it wasn't your scheduled time to accept those thoughts, then you would have to tell yourself, okay, well, I can't do that until 3:15 today, so I can't worry about this until 3:15. And by the time 3:15 came along, you would realize that you weren't really as worried about whatever it was at 12:15 that you were thinking about. So kind of a way that could be helpful or work. DBT, I love DBT therapy also. I love all therapy. DBT, dialectical behavioral therapy. I did a lot of DBT groups in my last job when I was working with kids with sexual addictions. And, they had this theory memorized, I think, because I instilled it into them. But mindfulness, building resilience to decrease stress, managing challenging emotions without getting overwhelmed, and interpersonal effectiveness, expressing personal needs without alienating people. So, you are using your interpersonal communication skills, you are using mindfulness, learning how to be present in the moment. We would do fun activities such as mindful eating. I mean, come on, who doesn't love to eat? Mindful eating. They say mindful eating could be good for weight loss too, if you're actually enjoying and savoring the flavors of the food. So different mindfulness strategies, working on being assertive and communicating yourself in a more effective way. Things like that fall under DBT. MBCT is cognitive therapy, changing irrational thinking plus mindfulness. So it's changing thoughts, but also including that mindfulness factor into it. I'll kind of leave that one at that. Some relapse prevention. We're focusing on coping skills. Coping skills are big with cognitive behavioral therapy. Social support and dealing with internal triggers. We want to develop refusal skills for when a drug is offered to us. We want to develop ways to cope with negative emotions when we experience them. Whatever coping skills that you might need, you kind of add them into your toolbox. Your textbook says that cognitive behavioral therapy is a strategy, but it is used in various other methods, including solution focus. The text is that cognitive behavioral therapy proposes various triggers and refusal strategies. Solution focus explores what has worked for the person and focuses on that. So like cognitive behavioral therapy, it is less prescriptive. So I would believe this to be, a fairly true statement because, we don't specifically always say, well, we're going to work on this type of therapy today. I mean, you are more than welcome to kind of introduce these types of therapies and get your client familiar with what you're talking about when you say them. But cognitive behavioral therapy kind of molds into some of the other therapies. So even with solution-focused therapy, once you've gotten that goal and you're asking them, well, how did you cope with that? You're kind of throwing some of that cognitive behavioral in and you're getting them to change their thought process behind it. So it kind of sneaks into other therapies. Something else I wanted to kind of point out is contingency management. This uses reinforcement and punishment per behavioral principles. I am not extremely familiar with this type of therapy as far as actually practicing it, but I want to share a little bit about it. For example, reinforcement could be a small prize for abstinence. A negative consequence could be you don't get to take home privileges in between methadone clinic visits. Some 4 basic steps to contingency management is identifying target behaviors, deciding what behavior you want to reinforce, verify demonstration for the target behavior, so set up a plan to quickly monitor that behavior, and the treatment goals must be verifiable. And third, provide motivational incentives. So decide what kind of tangible reward is feasible for that client, whether it be maybe a day pass or maybe a speaker or something. Decide if negative consequences will be employed. So decide if that is something that you're going to work on with the person. Research into cognitive behavioral therapy effectiveness. CBT is the most used method and therefore has been studied the most out of all the other methods. It is consistently more effective than the other methods as well, probably because it is the most used therapy and the most researched therapy. Project Match, cognitive behavioral therapy group reduced drinking more quickly than motivational enhancement therapy. So that was something that they found. There's equal effectiveness to motivational enhancement therapy and 12-step therapy, as we already know, and research has been primarily with white clients, however. So the last part that I told you we were going to kind of talk about was group therapy. And this is the most popular form of therapy for addiction. It is the most cost-effective therapy because it is one way to get everybody in the group at one time, so you're getting more people in the door. Cognitive behavioral group therapy is as good, and some studies say better than individual cognitive behavioral therapy. I used to ask my kids when I worked with them, which do you prefer, group therapy or individual therapy? And, I very seldom had people like group therapy more than individual therapy with the kids. But, every once in a while you do. And I think that sometimes you get people that like group therapy more so than individual therapy because they can interact with people of their same, that they are going through these same experiences and they're getting like that peer input. I think some people don't like group therapy because they're not getting to focus on their individual needs. They are, susceptible to whatever else the group wants to talk about or decide. And depending on the age range of your group or maturity of your group, you may get that group really off topic. So there's a lot of different thoughts out there about group therapy. I will say, traditional lecture and films is definitely the least effective for a group therapy. Often in group treatment, abstinence is the only goal because when you have a group of, maybe 8, 9, 10 people, you don't want people who are actively using in the group. It could throw everybody off. Does it happen? Absolutely. It happens all the time. And that is also sometimes a good group topic is, how can you educate people to, when they see people high, how can they respond? Some examples of groups is motivational interviewing group with teens in Santa Barbara. There were 6 sessions and they were open groups. There was a harm reduction group in San Francisco for 50 to 85% of dually diagnosed clients at a VA homeless drop-in center with no rules for sobriety or attendance. A solution-focused group compared with a traditional psychoeducational group for substance abusers, but focused on depression and interpersonal functioning. It was 6 weeks long and randomly assigned. Both traditional and solution-focused group members showed improvement. Solution-focused group improved more in depression and interpersonal functioning. So there's a little bit of input about group. Some traditional treatment continuum. We have most intensive treatment to least intensive treatment. We have detox, acute hospitalization, residential treatment, outpatient treatment, and transitional or sober living environments, which might be considered like your halfway or your 3/4 houses. We mentioned before, we have 0.5 early intervention, level 1 outpatient, level 2 intensive outpatient, level 3 residential inpatient, and level 4 medically managed treatment. Detox can occur at stages 1 through 5. It doesn't happen in stage 0.5, but it could happen anywhere from levels 1 through 4, or which I guess would be 1 through 5. Sometimes there are such things as like ambulatory detoxes, which is like an outpatient type detox. So that's kind of what this is referencing. And it can help people withdraw safely, but it's in limited value because, you're not actually removing the person from the situation. So you could help them get the detox, but they're going right back into their environment. So, there's mixed reviews on how effective that can be. But it can be done with good medical supervision. So if somebody is actively kind of following up with that person, it could be effective. Only 67% completed detox and only 11% went into treatment, according to a SAMHSA study in 2011. There were many barriers. We have talked about these several times. For example, do not facilitate engagement in further therapy. They were just referred to treatment. So they didn't help them get engaged in further treatment after detox. Overall completion rate of all kinds of substance abuse treatment was 44%. Residential is good for those without stable living environments or co-occurring disorders. So again, we mentioned the stable living environment, social supports, and the motivation to change is really good keys for a person to overcome addiction. Types of all community-based and foster sober living transition into the community. There's halfway houses, therapeutic communities, missions, or shelter homes. Outpatient is usually group counseling from once to several times a week. We've talked about that. And it could be anywhere from 8 to 12 weeks long. Aftercare is usually monthly meetings supplemented with 12-step programs or counseling. Um, you know, Following up with someone at least once a month to kind of make sure that you're doing okay. Intensive case management is usually for people with co-occurring disorders because, again, case managers have that role of kind of helping people find their other resources out in the community. In an ideal situation, we would have that continuum of, detox, inpatient, outpatient, aftercare, recovery, and it would be seamless. There would be no waiting lists from detox to aftercare. However, sometimes that doesn't always work in an ideal world, but that would be the ideal situation. The ASAM calls for several weeks of inpatient detox, then 90 days of intensive outpatient, and then 6 months or more of group and individual therapy and living in a halfway house or a therapeutic community. Anything less is asking for relapse. Now, that is a significantly long period of time, and unfortunately, not all insurance companies are willing to pay for that. But that, again, ideal situation, ideal continuum. The alternative, as we have discussed, is very different long-term model with a harm reduction or recovery management model extending over several years. The authors hope that the field moves to a strengths-based approach that assesses the stage of the person is in and gearing strategies to that particular stage, with options including, but not limited to, abstinence with the person making the choice. In some places this is the case. So that is chapter 8. And we will keep going with the next chapter. So stay tuned. Thank you for watching.